in the interview, and I say...
Phil Cavell is the author of the hugely successful book The Midlife Cyclist. After a serious heart event himself, which we discussed in the first video, he invited me to collaborate on this series with sports cardiologist Dr Nigel Stephens. An NHS Clinical Director of Medicine, Dr Stephens is also an international standard Masters track cyclist. This is the third video in this short series. The other two parts are linked at the end. For now, over to Phil Cavell and Dr Stephens.
One thing that we can maybe talk about is the influence of caffeine on your heart health.
Yes.
Because cyclists are addicted to exercise and caffeine, generally speaking.
Yes. So one of my children said of me, and they all think I'm quite a boring person, it all begins with C for you: cycling, coffee, chocolate, and the crossword, Dad. And they're right. And so I'm approaching this from a position of bias. Yeah. Let's just put this out there. When colleagues have looked, because it's a truism in medical practice that because caffeine is a psychoactive drug and because it's a stimulant and that's how it works as a performance enhancing thing, that it must be bad with heart rhythm abnormalities which are driven by adrenaline. And many, but not all, heart rhythm abnormalities are more likely to occur if we have a lot of circulating adrenaline. So it's the understandable sort of inference that if you take a lot of caffeine, you're going to aggravate abnormal heart rhythms. And if you go to see your GP and you say, I've had some palpitation, they'll say to you, please moderate your alcohol and stop drinking coffee. That's what they'll say. When people have looked at this in a more objective way and tried to look at the relationship between giving people caffeine and whether they get more heart rhythm abnormalities, it's been actually much harder to find a genuine link. And as I say, you're just going to have to sort of get a little bit of a health warning with this, that this is the bias of somebody who enjoys 3 espressos before he heads out on the bike in the morning. But the evidence is weak that caffeine causes or aggravates heart rhythm abnormalities. The evidence becomes very strong that if you take a drink, you will do so. So if you swapped Chianti for coffee, you'd probably do yourself a favour.
I said in the book that abstinence makes the heart grow stronger. And you know, if you're going to be an endurance athlete in your midlife, 50, 60, 45, you should be reducing your alcohol and probably cutting it out completely if you're building to a big event.
Yes.
And I think that's one of the things I think that you have been proved right on, especially with respect to AF.
Spot on. It's so complicated because it's embedded in our emotional lives. It's embedded in what fun means. It's incredibly complex. But if you take all that out of it and just say, well, what does the epidemiology tell us? It tells us that even small doses of alcohol are toxic to heart and brain and probably every other bit of us as well. The dose response of that adverse effect goes down to very low levels of alcohol intake, perhaps 3 or 5 units a week. So if it's more important to you to really optimize your sporting performance and to optimize your health, then I suggest alcohol-free beer is the straightforward way to go. And stop indulging in all sorts of complicated special pleading and thinking about it. Just do it.
Yeah, I'm with you. I totally agree. And in fact, you advised me. I had an arrhythmia in 2018, and you advised me change your life, Phil, and stop drinking. And that was the last time I drank alcohol.
Yes, and there's one other thing that's worthwhile saying in this regard, and that's around hypertension.
You might explain what that is.
Excuse me. So hypertension is high pressure within our arteries. So there's a natural biological distribution of pressure within our arteries. If we measure it in millimeters of mercury in healthy population, it would vary between 100 and 140 at rest. Due in part to genetic variation, some people have a higher number, and it can be due to medical conditions, but can it just be due to genetic sort of variation between people? And that's no problem in terms of the way that you feel, but give it 20 years and it'll damage your blood vessels and increase your risk of stroke, heart failure and kidney failure. So it's a huge public health problem, and as the population ages, it's more substantial every year. And I worked for, again, to sort of hat tip to another colleague for whom I have huge respect, a professor of clinical pharmacology, Maurice Brown in Cambridge University, whom I used to work for. Maurice said to me, when somebody comes with hypertension, ask them how much they drink. And it's powerfully true. A lot of people with mild hypertension can escape medication by stopping drinking. Alcohol raises your blood pressure.
Yeah, and a very good friend of ours and colleague of ours, Dr David Hulse, who contributes to the Midlife Cyclist, he describes it, alcohol as an obligate toxin. The body's obliged to deal with it first.
Yes.
It's a red flag to the body, and whether or not we're enjoying ourselves, the body isn't enjoying itself.
That's right. And one thing we might talk about, but even if not, about the value or otherwise of wearables.
Oh, yeah.
So if you have a wearable, particularly if it gives you a number relating to heart rate variability, and we can talk a little bit more about that, but basically the higher the heart rate variability at rest, the longer you live, all other things being equal. People who drink alcohol get a very powerful signal by measuring their heart rate variability that tells them you're poisoning yourself, because it tanks. 2 or 3 glasses of wine with your dinner, it's much reduced that following morning, and I think that's telling you that your physiology is stressed.
I've never heard a very good explanation about what heart rate variability is.
Sure.
Give it to me. All right. What a great explanation about HRV. What is it?
You're setting me up.
It's a hard one to explain.
All right. So, the maths is complicated, but you don't need to understand the maths to understand the concept. So everyone's pulse is not regular. It's not metronomic. And if you do it yourself and just feel your pulse at the wrist and breathe in and out deeply, you will feel it speed up when you breathe in and slow down when you breathe out. The process of slowing down is mediated by the vagus nerve. The vagus nerve runs from the base of our brain to most of our internal organs, and the vagus nerve tells everything to slow down and to de-stress. So the act of breathing will activate the vagus nerve. And so therefore, the degree of variation that we get from the speed up and slow down, expressed as a number mathematically, often measured in milliseconds, where you might say 15's bad, and Matthew van der Poel at about over 100 is great. Most people sit between those poles, and it varies according to whether it's a signal of whether our physiology is stressed. When our physiology is stressed, the vagus nerve switches off, the heart rate variability goes down. When everything is chilled out and relaxed, and the body is in a sort of beneficial state, the vagus nerve switches on, the heart rate variability increases.
So it's a slight paradox that you actually want the variation. You want your pulse to be less metronomic. You actually want there to be a variability between the beats.
Well, it may be more complicated. I mean, you're right, but sometimes people draw a false conclusion that it is the variation in the heart rate itself which is what's good for us. But perhaps it's more that that's just an indicator of what the vagus nerve is up to.
Right.
And the vagus nerve, in turn, is responding to all sorts of physiological stresses within our body. If we've got cancer, if we've got an infection, if we've got hyperthermia, there's huge physiological stress. lots of adrenaline is being produced, the vagus nerve is entirely silent. So it's not, I don't think, that the variation in heart rate is the thing that you seek. What you seek is a state where your body is not physiologically stressed.
Right. And in the book, I talk about this. I don't think it's in that chapter, but in another chapter about the autonomic nervous system, the parasympathetic and the sympathetic state. So what you're saying is the vagus nerve is bringing us into a parasympathetic state.
Yes, that's right. A state of rest, and there's quite a lot of interest in the world of sport and exercise science, which the theory, and I think the hypothesis not yet, I think, proven, which says that if you have an athletic person and you track their heart rate variability, you can prescribe their training regime according to their heart rate variability.
Yeah.
High HRV, go hard today. Low HRV, knock it back today. It's a pleasing concept, and the idea that we respond better to training if we train in a relaxed state. But although there's a lot of work going on with this, I don't think it's yet established to be definitely true.
So let's talk about the third shark circling in the water. And you described it to me as somebody turning up with performance that's changed, it's decreased, it's not,
Yes.
not as it was.
Yes.
But it's not really clear what's going on.
Yes. People doing regular sport and exercise are much more in contact with their body, and therefore much more aware when things are not working as well as they should. And it may be as straightforward as the cyclist with a hill that they ride up frequently and is now having to do it in the little chain ring, not the big chain ring. And people who measure wattage when they cycle and compare it with heart rate, and they're now finding that they have a higher heart rate for a lower wattage and therefore a decreased performance. So it's a common reason people come to talk. And it bumps into COVID from 2020 on in a huge way, because for many people it seemed to coincide with COVID and having COVID and not recovering properly from COVID. But it's by no means confined to that. And quite a common thing is to see often a very accomplished athlete who's reached late 60s, and they may have been of national or international standard when they were senior, and now they say, I can't keep up at the club run. And so you have to almost do a process of eliminating common things, which might be an explanation. And for some people, you have to end up saying, well, that's just the way it is, I'm sorry. And for some people, you can provide an explanation, and for some of them, you can provide a treatment. I mean, an obvious example that shouldn't reach the cardiologist and should have been dealt with already is they've become anemic.
Right. Which is a lovely diagnosis for you, because it's a magic pill, isn't it? You can give them an instant cure.
The one that's even better than that is overactive or underactive thyroid.
Oh, really?
You seem like a genius.
Oh, really? Yeah. So for these people, this cohort that rocks up with, you know, if not a sudden, a tangible
Yes,
change.
a real, that's not due to the ebb and flow of form.
Yeah, I've lost 50 watts.
Yes, and I've lost it for 3 months.
Right.
Because some people perhaps are a little too self-observant and might consult after a couple of weeks.
Right.
And I hope sympathetically say to them, well, me too. Maybe just give it a bit longer.
Sure.
But let's say, so more, as you rightly say, a concrete example might be somebody whose functional threshold power is normally 250 watts, and now it's 200 watts, and that's sustained, and it's been for 3 months.
Yeah.
And then you have to have a proper, structured, systematic approach to understand what's going on. And maybe helpful just to say a little bit about the way that you do it. So talk to them in some detail. You know, there may be all sorts of clues that they hadn't linked to this. They may have rectal bleeding because they've got a polyp in their colon and they're now anemic, as to to return to the previous example. If you examine them, there may be something blindingly obvious. They've developed heart valve disease and the blood can no longer circulate efficiently around the body. But sometimes that initial sort of inquiry yields nothing. They look quite healthy, but what they're saying is plausible and real. And so what you would do next is to evaluate their function objectively. We can do it with cardiopulmonary exercise testing, a ramp test on a bicycle, looking at inspired and expired gases, heart rate and blood pressure, and that gives you a great deal of information about cardiovascular and respiratory function and what might be wrong. And what I would often do, certainly for people beyond the age of 40, is what's called an exercise echo. So that's a cardiac ultrasound, which would probably show normal findings at rest, get them to go quite hard, and then ultrasound the heart as they're going very hard. And if there's a blockage in a heart artery, which is now manifest as a cardiovascular inefficiency, we would see that on the exercise ultrasound. And although that's quite a big deal for the person, I'm quite pleased because, first of all, we've identified it, we've made a diagnosis, and also we've got an excellent chance we can fix it for them.
Which is my next question. So if we take away the stuff that isn't anything to do with you, other than the fact you've been a good doctor and found it,
yes.
So let's take away the rectal bleeding and take away other issues, thyroid or whatever, and stick with the cardiovascular stuff. Is their prognosis, this group, good, generally speaking?
It depends. It's such a broad thing that the unhelpful answer is it depends.
Not helpful.
I'm sorry. So the prognosis might be excellent.
Right.
Let's take a person, so common things. A person in their 60s has developed a narrowed aortic valve. The aortic valve is the outlet valve of the heart. The heart pumps, the blood goes out through a one-way valve. That valve's opened and shut 100,000 times a day throughout that person's life, and it wears out. Just like all moving parts on all machines. It's wearing out, and the way it's wearing out is that it's opening to less fully than it should. So it opens partly, and it reaches a point where the heart cannot push enough blood out to meet the body's demands, and so that may manifest simply as a loss of performance. We can fix that. You can replace that worn out valve with an artificial valve, either with a keyhole approach or with a cardiac surgical approach. And after a period of rehabilitation and re-enablement, that person can go back to normal. And although doctors are a little sort of reluctant to talk about cure, it's curative. They're fixed. Good. And as long as it's not so far gone as the heart itself has failed, as long as we've seen it before that point, it's highly rewarding to treat because you can make the person so much better. If we take perhaps another common but more complicated example, you take myocarditis. So that's different. That represents inflammation of the heart muscle. And that may be caused by a virus, and it may be caused by an inflammatory condition such as rheumatoid arthritis, or it may not be entirely clear what's caused it, but what we can see is the heart muscle is inflamed and a bit like a boil in our skin. It's angry and it's not functioning as it should. And so when we look at the heart, it's not contracting well. And when we do an MRI scan, we can see that that's because the heart muscle is inflamed. And that's more involved for several reasons. The first is that you have to tell that person to stop exerting themselves. And I'm approaching that as a person who wants to facilitate people doing exercise, but I can't...
I can back you up on that.
But I can't do that for everyone.
No.
So the first thing is to say, sorry, we've got to let this get better. For some people, it's causing a severe degree of abnormality, and they may require strong medicine and anti-inflammatory drugs such as intravenous steroids to damp down the process of inflammation. And we may need to give medication which can help in the healing process in the heart. And then we need to keep a careful eye on that person to see the process of inflammation resolve, and hopefully the heart muscle function improve. So there it's a more complicated group, and the outlook may be good, but sadly in some cases it may not be so.
And for clarity's sake, so the context here is that exercise, and especially intensive exercise, is acutely inflammatory if it's then chronically anti-inflammatory. So
Yes.
you're trying to avoid the acute inflammation phase on top of...
Yes, it's observational stuff that again comes from Scandinavia, where they found people who had clearly got acute myocarditis, continued to engage in moderate and high intensity exercise, did worse than people who rested. It starts with that. And that's now part of coaching law. People are worried about that. And so if you've got a viral infection and it's from the throat and above, carry on. And if it's below, stop, or at least...
And that's not nonsense. That's you stand by that.
For sure. If you train with flu, you're stupid.
Yeah. Because it's already an inflammation and you're...
Well, for two reasons. First of all, you're not getting training benefit.
No training effect, yeah.
You're not getting any training benefit. And second, you may do yourself harm.
Yeah.
So just, have a word with yourself.
Absolutely right. I mean, and this is where having worked with you for, I don't know how many years now, many, many years, what I can say is that, and this is where I think you're superb with my clients, is you totally understand they've got a niche to scratch.
Yes.
And they get it, and they know that you get it. And they know that, if you say, look, get on your turbo trainer and turn your legs over, heart rate, 100, 110, you know that that's important for them to do that, even if there's very limited training effect.
Most people who come to see me for sort of further opinion have already had excellent care. Whatever type of heart trouble they've had, it would be rare to think, I wouldn't have done that.
I've never heard you say that in all the years.
No, and I've very rarely come across it. But what the colleague who's looked after them, the perspective they have not had is of the person for whom exercise is as important as their marriage or their job. And so it's a big deal to say, turn that dial down for that person. Yeah. And the point of intuitive mutual recognition comes where I would say, I don't like not training for a day. I'm really bothered if I can't train for a day. And so I might bring a bit of knowledge to the party, but we are, to mix the metaphor, we're on the same page.
But maybe you're part of the tribe.
Yes, and to be honest, in the cycling world, I might well know them, or at least know somebody that knows them.
My thanks to Phil and Nigel. If you've not yet seen them, the first video is here, and there's also a link to my older athlete series. I'd be hugely grateful if you'd click one of these, and I'll see you again next time. Goodbye.